Hi everyone, welcome to the Basic Dysrhythmia Crash Course. I'm just going to give you a brief overview for those of you who haven't seen rhythms in a while. It's by no means an actual Basic Dysrhythmia class. And I'm just going to go briefly through anatomy and all the rhythms so that you know what you're looking at when you see a rhythm, okay? So let's start with some anatomy. Okay, don't laugh at my drawing, but this is my version of a heart, okay? And we have 4 chambers. So we have blood coming to the heart from the body. The upper body, the lower body comes into this chamber right here called the right atrium and goes down through this valve down into the right ventricle. Okay, this blood here does not have very much oxygen in it because it just got used by all of our tissues in the body. So it's returned to the heart because we need to get some more oxygen. Okay, so it goes to, this is how I draw lungs. Lungs. So the right ventricle pumps the blood to the lungs, and that's where it picks up the oxygen. And it comes back to the heart, and now it comes into this chamber here. This is the left atrium, and then down through this valve. We're not going to actually talk about valves in this class. So this is the left ventricle, right, which is very important chamber because it pumps the blood back to the body, okay? So it has to follow this particular pathway because otherwise it's not going to, the oxygen is not going to get to our cells in the manner that it needs to. Our cells cannot function correctly without oxygen and nutrients. All right, so that's the heart in terms of circulation. But now let's talk about the heart in terms of conduction, the electrical conduction system. So, all right, I'll use orange for this. All right, so the electrical impulse starts here at the heart's pacemaker. We call it the SA node. And it travels through all these little pathways here. These are called the internodal pathways. And then the AB node kicks in, okay? B node. And the electricity travels down through the bundle of His, down through the bundle branches, and then up through the Purkinje fiber. So it just goes in this direction here, up this way, Purkinje fibers. So once again, it starts in the SA node, our pacemaker, and then travels through the internodal pathways. The AB node picks it up, then the electricity travels through the bundle of His, down through the bundle branches, and then up through the Purkinje fibers. And does it have to travel in this sequence? Yes, it absolutely does, because you need the electricity to generate an actual muscle contraction. We have mechanical cells and we have conduction cells. So the conduction cells are responsible for transmitting electricity through the heart so that the mechanical cells can produce a contraction. Let me show you. You're probably wondering, well, how is it that the electricity traveling through this pathway ends up looking like this? How does this equal this? Well, I'm going to tell you. Let's see here. All right. You know how we have, we put leads on our patient's body, right? We have the white lead here, the black lead here, we have the green lead here, and the red lead here, and then our brown lead here in the middle, okay? And we put those leads on the body and we get a picture. And this picture is essentially just a representation of the electricity flowing through through the conduction system, but it picks up the different perspectives. We might be looking at this lead to this lead, okay? And that's lead 2 when you're going from a negative pole to a positive pole down here. We might be looking at the electricity traveling through the heart this way, or maybe this way. And so when you get a 12 lead EKG, for example, and that's when you have tabs all over the body, it's looking at the heart from so many different angles so it can determine whether or not there's an issue going on. For instance, maybe there's not enough oxygen getting to the heart. And so where is that taking place? You can tell by looking at it from lots of different angles and seeing where the problem is in the heart. But for our purposes, we're going to focus on lead 2, which is reading the electricity from a negative pole up in this corner down to a positive pole in this lower left-hand corner. So we have a negative and a positive down here, and we're reading in this direction, okay? All right, so start with orange. So the SA node fires, and we start with our isoelectric line. Isoelectric line is essentially this baseline right here before you have an upswing here. So it's our baseline, it's our starting point, and when electricity travels through from the SA node through the internodal pathways through the atria, atria is plural for atrium, it's traveling through the 2 atria from a negative to a positive pole. So you're heading toward the positive pole. That's going to give you a positive inflection. So it's going to go up from the baseline, and that gives you a P wave. So the P wave essentially represents the electricity traveling through the atria. Does that make sense? Okay, so now the AV node fires, and it's going to continue to travel in this direction, right? It's traveling from the AV node down through the bundle of His, down through the bundle branches from negative to positive, and so it's heading in a positive direction. It's going to give us a positive inflection this way, and then it turns and it goes up through the Purkinje fibers on both sides, the Purkinje fibers. And so when it's going in this direction, you're heading from a positive to a negative pole. So now you're going to get a negative deflection, and it's going to return to the baseline here. And then lastly, after all of the cells are depolarized, let's make sure we label this. This is the Q, the R, the S. After all of the electricity travels through those cells and depolarizes these cells, and depolarization just essentially means that the impulse has traveled through it. There's a lot of physiology behind it, but for our purposes, we don't need to get into that. But all of the cells have to reset themselves. I call it a rejuvenation. So you have to recover from all that electricity traveling through and reset, and that's where you get the T wave. So that's the repolarization or resetting of the cells so that we can start all over again, the PQRST, okay? And ideally, you have PQRST, PQRST, PQRST over and over and over 60 to 100 times a minute. So now you know that the P wave represents the electricity traveling through the atria, the top of the heart, and that causes the atria to contract and push blood down into the ventricles, right? So the electricity travels in this direction so that these chambers can contract and get the blood down into the ventricles. And then the electrical impulse travels down through the ventricles and up this way, up through the Purkinje fibers to get the ventricles to contract and push the blood out to the body and the lungs. Okay, and so that's why we absolutely need it to go in this sequence. You need for the heart to pump in this direction. Lub, dub, lub, dub, okay? So, with those fundamentals behind us, we can actually now talk about our basic rhythms, right? Our good rhythms. We want to know what the most basic, best rhythm is, and you probably remember this. You may know all of this already and don't feel you actually need a refresher, in which case, if you're interested in something more in depth, we have basic dysrhythmia classes, we have 12-lead EKG classes, so definitely look into those, but I'll continue on with just the basics. I'm hoping that you can see this. So we have ticks at the bottom, and sometimes they're at the top. It just depends on the EKG paper, but most EKG paper has ticks on it, just timing out what's happening here. So we have the x-axis here is time, right? So from this tick to this tick, we have 3 seconds. And from this tick to this tick, we have 3 seconds. So this is what you would call a 6-second strip right here. And so you're going to count. Here's how we actually figure out the heart rate. It's a real fun, quick method. 1, 2, 3, 4, 5, 6, 7 QRS complexes between those tick marks, okay? So how many did we say? Did we say 7? Just add a 0. And so the rate of this heart rhythm is 70. Does 70 sound good? 70 is actually very good. So we turn to this little paper right here. So the rate of this guy here is 70. So that's good. Is it nice and regular? Just eyeballing, you can see it. That's nice and regular. Okay, so yes, it's regular. What about a P wave? Is there a P wave? Well, I see a P QRST, P QRST. So there's a P wave for every QRS. So yes, there's a P wave. And is it upright? That's what's most important. Yes, it's upright. Okay, and is it 1 to 1? So 1 P wave for every QRS. 1 P, 1 QRS. 1 P, 1 QRS. 1 P QRS. In other words, it's not P, P, P QRS. That would be a bad thing. You want it to be P QRS T. P QRS T. Because you need for the electricity to go through that pathway that we discussed. So you might actually stop and think, well, why do you have 2 different rhythms here? And these aren't 2 different rhythms. These are the same rhythm. This is the same patient, but this is in 1 lead. Remember how I told you that we're looking at all sorts of different directions of the electricity traveling through the heart, or all different angles, at the different angles, so you can see what's happening over on the lateral side of the heart, or what's happening over in the posterior part of the heart. So this is just in 2 different leads. So these are 2 different aspects. And in lead 2 here, you can see how it says lead 2 right here, or maybe you can't see it on this video, but it shows the P wave is upright. And so in lead 2, yes, we absolutely want the P wave to be upright. And is it 1 to 1? We just talked about there's 1 P for every QRS, so it's yes. When these are true, you have sinus. Now sinus what? Depends on the rate, okay? So is this sinus rhythm, sinus bradycardia? And the way that we know this, let's draw this, 60. So less than 60 is sinus bradycardia. We just call it Brady. Sinus rhythm between 60 and 100. Sinus tach, or tachycardia, from 100 to 150. But now when you hit over 150, you have a rhythm called SVT. It's supraventricular tachycardia, and I'm going to show you that. But I just wanted you to see that sinus brady is heart rates down here. These are all heart rates. Sinus rhythm is between these 2 heart rates. Sinus tachycardia is between these 2 heart rates, and then SVT is up in this area here. So this one here, we decided the heart rate is 70, so it's sinus rhythm. Okay, good. Here's one. I'm gonna use my little magnet. Here we have tick, tick, tick. Okay, so that's 3 seconds, 6 seconds. We're gonna count 1, 2, 3, 4 QRS complexes, add a 0. The heart rate is 40. And so we're gonna change this to 40. Is it regular? Look at that. It's so nice and regular. Good. In both leads, you can see it's nice and regular, right? Is there a P wave? Let's look. Oh, there's a P wave. For every QRS, there's a P wave. So yes, it's present, it's upright, and it's 1 to 1, so it's sinus. So it's sinus, but the heart rate here we said was 40. So where does that put us? That puts us down here in the sinus bradycardia. So this rhythm is sinus bradycardia. All right, let's look at this strip here. Here's some tick marks here, here, and here. So let's count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. I see 12 QRS complexes within this 6-second strip. So this becomes a heart rate of 120, right? Just add a 0. Is it regular? Look at it. It looks super regular. It's very timely. It's falling right where it needs to fall. Is there a P wave? Ooh, P wave, P QRS, P QRS. You can't really see a big S in this lead here, but do you see how you see a big S in this lead here? P QRST, P QRST. So it's upright and it's 1 to 1. So it's sinus. The heart rate we decided was 120, so that puts us up here in this category, sinus tachycardia, okay? And let's look at this one. Ooh, look at this. Let's count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. I counted 19, and that puts us up here at 190. That's SVT. Now, SVT is true if it's narrow complex, and these are narrow complexes, just like all the other strips that we've been looking at. But let's talk about wide complex just briefly, and we're going to get back to this. But do you see the difference between this and this? This is wide complex, so this isn't. So this is ventricular. Anything when your QRS is really wide like that, this becomes ventricular as opposed to supraventricular tachycardia. So this is SVT and this is VTAC, okay? And we're going to get back to VTAC. We're going to cover our lethal rhythms later, but I wanted you to see the difference. SVT has these narrow complexes, and we see this rhythm a lot. And you would treat this, you'll see them treating this with adenosine. And if your patient is in symptomatic bradycardia, is super low and symptomatic, you'll see them giving atropine for those patients. All right. Oh, here's another real life strip of SVT. You just can't miss it when you're looking at it and it's tacking away like that. It's funny, if you go into the NICU or look at a rhythm of a baby, this is what it looks like, right? Because their heart rate is so much faster at rest. But this is abnormal for an adult, obviously, because the heart rate is more than 150, and we don't want our heart rates at rest to be more than 100. So this one is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So that's 150, 160 if you count this one right here. So yeah, this is definitely SVT. Okay, so if all of that makes sense, we're going to move on to another rhythm that you see, and this isn't abnormal. This is actually something you see with runners or very athletic people. You might see, you know how we usually have a PQRST? What if the P wave is inverted? And remember, with this, we wanted the rate to be somewhere 60 to 100 ideally. You want the rhythm to be regular. The P wave, you want it to be yes and upright, right? That's what makes it sinus, is if this is upright and it's 1 to 1. But what if it's yes, but it's inverted? You call this junctional. show you some more strips. Okay, do you see here how the P wave is present? It's nice and regular. I love that. And the P wave is inverted. It's present, which is good, but it's just inverted. And so when you have an upside down P wave that way, then you have a junctional rhythm. And junctional rhythm is, you'll find it to be 40 to 60. And if it's more than 60, let's see, this is 6-second strip, and this is 1, 2, 3, 4, 5. So this is a heart rate of 50. So yeah, it falls within the general guidelines. But if it's more than 60, you would just call that accelerated junctional. If the heart rate is 70, it would be an accelerated. And 70 doesn't sound very accelerated, but for junctional it is, because the impulse is being started not at the SA node, but somewhere a little lower than that, okay? Somewhere right in the middle. All right, so that, and I wanted to show you that junctional can also be without a P wave at all. The P wave is actually coming, it's actually behind the QRS complex, so it appears as though there's no P wave at all. So junctional can have an inverted P or no P, but it's still regular, and that matters. Okay, so if it's nice and regular, see here how it just falls. If you measure these from complex to complex, it's nice and regular. And how do we measure from complex to complex? Well, you just grab a random piece of paper. Let me see. Where do I have a random piece of paper? Oh, here's a random piece of paper. If I do this and go from here to here, right? Then I pull it this way, and then I pull it this way, and it just falls. It falls exactly where you would think it would fall. So it's nice and regular, but there's no P wave. And so if there's an inverted P wave or no P wave, but it's regular, we just call this junctional. And here, I'll give you another one here. Here's a junctional rhythm. Ooh, this is a 6-second strip. 1, 2, 3, 4, 5, 6, 7, 8. If it's more than 60, generally junctional, again, falls between 40 and 60. So if this is 80, then it's an accelerated junctional, okay? But again, there's no treatment. Unless the junctional rhythm is going so slow that the patient is symptomatic, we would treat it, but it's actually pretty common with athletes, once again. So those are rhythms that we're not terribly concerned with. Sinus rhythm, no. If it's bradycardia, if it gets too slow and they're symptomatic, then that's cause for concern. And again, you give atropine for symptomatic bradycardia, and with tachycardia or SVT, you're going to end up, if they're symptomatic, you end up giving adenosine. And you just need to slow things down, right? And a lot of times they'll give metoprolol or some beta blocker to try to get it down as well. Okay, now we're going to talk about irregular rhythms. All right. So remember how I said that the rate you want to be between 60 and 100, and you want it to be regular. You want it to have a P wave, ideally upright. 1 to 1, very important. 1 P wave for every QRS. The PR interval and the QRS, those are intervals. On the on the EKG, you're measuring the interval from the P to the R, and the QRS is from here to here. And when you measure these, they need to be within certain limits, but we talk about that in the full course. So I don't need you to be too concerned about this right here, because that's too much detail for our purposes. But this would be an ideal circumstance. If you have a rhythm that's not regular and there's no P wave, that's trouble. That's when you have AFib. Okay, I'm going to show you what AFib looks like. Here we go. Look at this strip here. Just looking at it, if it's not regular, is it? It's like it's here from here to here, and then here to here, and here to here, and here to here. They're all different distances, so it's not regular. Is there a P wave? Well, sometimes our brains want to try to find a P wave in there, but it's just a squiggly line really in there. So what's happening is in our heart, the SA node is not in charge. There's no atrial kick. So you don't have that jump start and that nice forceful contraction through the atria. You don't have that. You just have little spots here just kind of fibrillating. And so you can imagine that blood gets kind of stagnant if it's not forced down into the ventricles, and it kind of pools in all the little nooks and crannies, and clots can develop. That's why AFib is a bad thing. So if your patient goes from sinus to AFib, oh look, I happen to have a strip of that. Look at this. Beautiful sinus rhythm, boom, 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 and then all of a sudden it goes irregular here and there's no P wave. So again, AFib. So that's short for atrial fibrillation. Irregular. And number 2, no P. And this is irregular, no P. This is regular with a P wave. So we just went from sinus rhythm into AFib. And the sooner you figure that out, the better, because you need to convert that patient so they don't develop clots. And you need to rate control it. Now, does grandma sometimes end up in AFib for 20 years? Yeah. Now, she's going to feel weak. And AFib definitely decreases your cardiac output, so you're not getting that forceful kick, and you're not getting really good. Your cardiac output is just not going to. It's going to impact your blood pressure at times, and you just don't feel as good because not all of your tissues are getting the blood and the oxygen that they need in order to really feel optimal. So we would rather our patients be in a nice sinus rhythm. But if they've been in AFib for a long time, you don't want to convert them out of it because you're going to bust a clot loose. And so you want these patients to be on anticoagulation, and you want them to be rate controlled. Let's see how rate controlled this patient is in their AFib. Let's look here from here to here to here. So that's your 6-second strip right there. Let's count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's about 1. It's almost 11. So I would call that it's somewhere between 100 and 110. So let's say this is heart rate. Heart rate would be 105. Okay, so here's the AFib. Let's see, 100 here. Here's the AFib diagram or relative to heart rate. So controlled AFib if it's less than 100. But this is more than 100, this is 105, so this becomes uncontrolled AFib. Now, anything more than 150, we're still calling SVT because you can't tell with SVT. I'm going to pull back our SVT strip. When you have a patient in SVT, you can't tell if there's a P wave or not because that's the T wave. The P wave blends with the T wave, and so it's going too fast. You have to slow it down to see if you even have a P wave, okay? So you're, again, SVT if you have a narrow complex rhythm, more than 150. But uncontrolled AFib is also known as rapid AFib. I find this to be very region dependent. There's AFib, if you want to sound really fancy, AFib with RVR. RVR is rapid ventricular response, but all of these are synonyms for one another. You can use them interchangeably. They're in rapid AFib, they're in AFib with RVR, they're in uncontrolled AFib, same thing. And some people even call it rapid AF for AFib. I hear that in the Northeast. Okay, so that's AFib, and let's see. So I showed you the rhythm that goes from sinus into AFib. Here's another rhythm here. here's our 6 seconds, right? 1, 2, 3, 4, 5, 6, 7, 8. So heart rate 80. Oh, well, at least it's rate controlled. So we would call that controlled AFib. But do we want our patient to be in AFib? If they have previously been in sinus recently, no, we don't want them to be in AFib because we want them to have a good atrial kick and have the SA node in charge, large and in charge. Okay. Now, AFib has a sister rhythm, and it's my favorite rhythm. Let's see here. I'm going to show you this. Look at this. These here are flutter waves. Do you see how they're pointed here at the tops? They just look like this. Right? And you have your QRSs in there. But they look sharp. And some people call this sawtooth. Some people call it shark teeth. What else do I hear people call it? But it just looks jagged, right? It's not a pretty round P, QRST. It's not a beautiful P. It's an F wave. We call this F wave. So this is a rhythm we call A flutter. And it's kind of, sometimes you'll see a patient that's going between AFib and A flutter and AFib and A flutter. And we want to convert patients out of both of those if this is a new rhythm for them, okay? The problem with A flutter is that the atria is going so fast, or the conduction through the atria is going so fast that it could actually cause the QRS or the electricity traveling through the ventricles to go that fast, and that would be very problematic. But in both cases, you're not getting an ideal cardiac output and you want to convert them. And how do we convert patients out of AFib? Well, we use diltiazem. I see us using amiodarone. And you want to use a beta blocker to get their heart rate down if it's going too fast. Okay, so now let's talk about early beats. Sometimes you'll have, PQRST, 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 and it's nice and then you'll get an early one, PQRST. See here, it's here, here, here. It should have fallen here, right? But it didn't, it came early. So, but it looks just like all the other ones here. That's just called a premature beat. Because it's still narrow and it has a P wave here, we know that it's still coming from somewhere in the heart, in the atria. So instead of the SA node, like SA node, SA node, SA node, and then what kicked in here? Just a rogue spot, conduction cell in the atria somewhere. Maybe it was here or maybe it was here, but they decided to jump in there and beat the SA node. And that doesn't hurt our patients. If you have too many of those, that might be a sign that they're trying to go into AFib, but for the most part, PACs are harmless, they're benign. And here's a strip of that. You see here you have boom, 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 and this one comes in early. Do you see how it did that? In the morphology or the shape of the P wave is a little different. It's kind of spiky relative to this here. It just looks different. So you can tell that it's coming from not the SA node, it's coming from just another spot. Instead of the SA node, it's just coming from another random spot in the atria. But there's a P wave, so it is still atrial. So we call this a premature atrial contraction. I know, I have terrible writing, but that says premature atrial contraction, better known as, we just call them PACs. PACs are not going to hurt us. Too many of them, and our patient might be going into AFib. Okay, what if a rogue conduction cell down here decided to kick in before this right here? Well, it's not going to have a P wave at all because it's down here, and so this isn't really contracting. So I'm going to show you what that looks like. When you have something down here taking over, down in the ventricles, we call this a premature ventricular contraction, okay? And so this becomes a PVC. Okay, so, and PVC looks like this. It just looks wide and bizarre. I'm going to show you another one. Here's a real life one. A real life strip here. We have one here. We have one here. A nice and sinus rhythm. And oh, we got another one there. Do you see how they all are the same shape? I'll do back this one here. They're all the same shape. That's because they're all coming from the exact same random spot. So this one here, so this is beating boom, 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 boom. This guy decided to jump in just a little early, and it looks like that. Now, is it ideal for a ventricular conduction cell to jump in? Every now and then, no big deal. We all have that going on. But what if it happens every other beat? Do you see here, normal beat, PVC, normal beat, PVC, normal beat, PVC. When it's every other beat, we call that bigeminy or bigeminal PVCs. Okay, what if it is every third beat? Ooh, look at this. 1, 2, PVC. 1, 2, PVC. 1, 2, PVC. 1, 2, PVC. Ooh, does anyone, I bet you can guess what that's called. It's called trigeminal PVCs. Okay? All right. What if you have a bunch, what if you have beautiful sinus rhythm, or this is actually sinus tach in the 120s, but it's sinus tach, boom, 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 and then all of a sudden, this kicks in here. Well, so what's happening here, and they all, this one looks a little different, but they all pretty much look the same here. So it's monomorphic, one shape, with just one morphology. So that would be here. The SA note is boom, 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 and then all of a sudden this one goes boop, 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 boop. How many times did it do that? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 PVCs in a row. 12 PVCs is the same as a 12 beat run of V-tach, ventricular tachycardia, okay? So all V-tach is a bunch of PVCs in a row. If you have, let's see, you have PQRST, and then you have 1, 2, 3. If you have 2 in a row, let's say you just have 2 in a row, and then PQRST. If you just have 2 in a row, that's not V-tach. 1, 2, and then went back to sinus. That's just a couplet. So you can have a single PVC, you can have a couplet of PVCs or a PVC pair, but once you have 3 in a row, it becomes, so PVC 1, 2, and 3, then it becomes V-tach, okay? And this one here, this is a real life example of a 12 beat run of V-tach. Oh, and here's a regular beat, PQRST, and then look, 2 more PVC. So this is a PVC pair. So that's a 12 beat run of V-tach and a PVC pair, okay? And then back to sinus tach. All right, does that make sense? Now, what if the patient stays in it? What if patients stay in that rhythm? Oh, look at this. This patient stayed in that rhythm. You call this sustained V-tach. This is just a bunch of PVCs all in a row. Can you imagine if this right here, if this spot here permanently takes over? Is this patient going to get good cardiac output? There's no way you're going to have a decent blood pressure if this is taking over. Now, it might be perfusing, and maybe it doesn't affect the cardiac output right away, but when you see a patient having this many PVCs, when they start to have a lot of PVCs, first of all, you need to check their electrolytes. But actually, before checking electrolytes, get a blood pressure and be able to see if these beets are perfusing, because maybe the patient is still getting blood to all of his or her cells, but you will likely see that their cardiac output will start to be impacted by these PVCs, because you're not getting your normal pathway, right? Your normal pathway. So the heart isn't going to, as a result of the electricity not traveling through the heart in the appropriate pathway, then you're not getting the atrial kick, you're not getting the heart to pump in an ideal fashion, okay? So that's VTAC. That's a lethal rhythm. If you want to check to make sure that the patient has a pulse, always check your patient and don't trust your monitors, okay? Go in there and check your patient, make sure that they even have a pulse. If they're unresponsive and you check a pulse and they don't have a pulse, then obviously we need to start chest compressions. That's a whole different scenario, but with a patient not in this current COVID climate, and the patient's a full code, then we would absolutely give chest compressions, and we need to defibrillate this patient, right? This would be, if there's no pulse, then this patient, it becomes a shockable rhythm, okay? So there is VTAC with a pulse. And what do you want to do for that? Well, you want to give amiodarone, and you consider cardioversion. VTAC, no pulse, defibrillate. And then let me show you another rhythm. Look at this. This just looks like a squiggly line. This looks like a kindergartner was drawing on the wall, right? Does that look good? Now again, this might be what it looks like, and the patient's just moving around in bed, or respiratory therapy is doing some pulmonary toilet on the patient, doing some PPT on the patient, but this is bad. If you check for a pulse and this patient has no pulse, then you need to do something fast, right? And that rhythm is called VFib. One more look at it. Squiggly line, that's bad. That's VFib. You're going to defibrillate. And then, what if it's just a flat line like this? That's asystole, right? Asystole. You are not going to defibrillate that rhythm. There is no electricity going through this heart, so you don't defibrillate. All you can do is do chest compressions, and so just chest compressions and epinephrine. The co-team will come and give epinephrine. But that's all you can do for asystole. And if the patient's on an AED, if you hook them up to the AED, it'll tell you that no shock is advised for this patient, okay? But these are the ones, pulseless VTAC and VFib are the ones that you want to defibrillate. And the machine will tell you to do that. Oh, look at this. You have a beautiful, what is this? What are these waves here? Do you see here how it's kind of sharp looking? Those aren't P waves, those are F waves. This is atrial flutter. So the patient's is here in A flutter, and look what happened. They went into asystole. Ooh. And then they came back. The SA node kicked in again. Look at that P wave there. The SA node kicked in here, and this right here, all of that there is just movement people running in and checking to see, are you okay? Are you okay? So that's good. Now, hearts get tired. Sometimes you have congenital heart defects. There are many reasons why patients end up with artificial pacemakers. But when a pacemaker is placed in a patient, they have leads, let's say, and you know that the patient has an implantable device there, and you see it in their skin, right? There's kind of, you can feel it right under the skin, and let's see, right around here, you can feel a pacemaker. So if only the SA node or the atria need to be paced, then right here you have just a paste. If it's just one wire in the atria, you have a paste. And you see here how the pacemaker is creating a P wave. Pacemaker is creating a P wave. Pacemaker is creating a P wave. Okay, so that's what you call a paste. What if you have a patient whose ventricles are being, do you see here how there's no P wave? It's just a pace spike in front of the QRS complexes. And these QRS complexes look super scary. You might hook up a patient and it looks like a bunch of PVCs. But turn on the little pacemaker function and see, and the little spikes will be colored. In which case, this right here, you'll say, oh, this is just V paced. And then lastly, what if you have two spikes, and then a QRS, two spikes? So there's a spike creating a P wave and a spike creating a QRS. Well, that becomes, that right there is, let's do that. That is, oh, I'm out of view, AV paste, right? Okay, so that means that you have AV paste. You have leads going to both the atria and the ventricles, okay? Oh, I'm leaving so much out, but those are the basics, guys. And before I leave, I just want to tell you that when you see something on the monitor, don't always believe that that is what is happening in the patient's heart. You have to check the patient. We have seen time and time again when a patient would have a beautiful sinus rhythm, kid you not, they would look like, well, I can't find my sinus rhythm, but they would just be a beautiful sinus rhythm. They would look like this, but they're unresponsive and they have no pulse. Sometimes a patient is in what you call PEA, pulseless electrical activity. PEA can look like anything. It might look like this. It might look like this. It might look like, I don't know. It might look like this, right? It could look like any of these things, right? It could, but don't assume that just because you see electricity going through the pathway that it is always generating an actual muscle contraction. Because patients can certainly have electricity going through their heart and it's not actually beating, okay? There's no mechanical response. So always keep an eye on your actual patient, and when you run in the room, you treat the patient and not the rhythm, okay? By the way, pulseless electrical activity, the defibrillator will tell you, or the AED will tell you that no shock is advised.